In terms of hamstring morbidity, we see persistent hamstring weakness, which again, I don't think is a surprise to anyone. In rare occasions, we can see numbness around the patella, which is usually associated with harvesting the semitendinosus. And I'm going to talk about that in a separate slide, where we see kind of numbness around that region due to nerve injury. One thing I've started to see a little bit more of, and I will stress I've probably only seen about 5 of these in the last 3 years, is essentially retraction of the semitendinosus. So as I explained before, we know that in most cases that tendon will regrow and reattach anatomically. However, there are some variations to that. So occasionally we can get reattachment to locations that are not desirable. Sometimes during the reattachment process, if the hamstring gets overloaded, it can basically fail and it can retract up the leg, and that becomes a big problem. So in this patient here, if you can see on the green arrow, that's his unaffected side. So as he contracts, you can see the semitendinosus tendon quite clearly, and it's quite proud underneath the skin. As we look to the affected side, not only can you see kind of marked atrophy and deformity in the posterior thigh region, but there's that absence of proud tendon from the semitendinosus. This is a gentleman I saw about 3 years ago. This was kind of one of the first ones I really kind of identified in this case series. He was a very high-level football player, playing semi-professionally in Western Australia. He'd had an ACL reconstruction with a hamstring graft. When he came to see me, he was reporting he was getting quite frequent hamstring strain-like symptoms. So he would be playing for sport, he'd be training, he'd break out in a sprint and he'd get kind of like a cramping type sensation or what he described as a strain. The unusual thing for him is that it would often recover within a couple of days or under a week, and he'd be back out training without too many issues. So it was kind of a little bit of a curious one for his treating physios at the time, but also for myself. One thing that stood out is that early on in his rehab, he'd had an episode, so he's putting on his shoe and he felt it quite a sudden pain in his posterior thigh region, which was just put down as a kind of minor tweak of the hamstring. It didn't limit him too much in terms of his ACL rehabilitation. He was able to crack on. However, he did report kind of ongoing issues with heavy hamstring curls, and it wasn't until he got to sprinting that it started to really kind of limit him. When I saw him, he'd had about 4 or 5 episodes of these in the first season that he returned, but as I mentioned, he would kind of recover. When we did some hamstring strength testing on him, the first thing I noticed was this huge defect in his posterior thigh region that no one had really noticed at that point. So essentially, once we sent him for an MRI and reviewed, his distal hamstring tendon had basically torn away when it was trying to reattach, and had retracted up his leg, which was causing that defect. In terms of how we manage these kind of severe retractions, unfortunately the options are not good. Surgically, surgeons don't really want to touch them. Because the hamstring tendon's retracted up the leg, there's not really a lot for them to work with, and any kind of surgical procedure would be a hit and hope, and certainly the surgeons I've discussed this with, a lot of the time they're concerned that they'll do greater damage rather than help resolve the problem. There may be a role for PRP. We have a patient this week who's going in for a high volume PRP injection to try and stimulate some kind of healing response around that area to see if we can get some form of reattachment. But at this stage, we don't know. As I mentioned, I've only really seen 5 of these severe ones and some minor ones that generally just got better over time. From a physiotherapy point of view, they're very hard to load in any way, shape or form. So often any form of hamstring loading will bring on these kind of cramp-like symptoms or strain-like symptoms in that area, which makes it hard for us to address the remaining hamstrings. It's usually a process of trial and error. Every patient is a little bit different. What I've found clinically is that hip-dominant exercises seem to be more tolerable than knee-dominant exercises. So often they can tolerate RDLs, but hamstring curls or Nordics are really challenging. Outer range exercises, so close to extension, seem to be better tolerated in terms compared to inner range exercises. That may relate to how the hamstring activates, but I don't think we can make too many assumptions about that. Sometimes we can give them a lateral bias kind of hamstring exercise. So this is an example where I've kind of externally rotated the foot and got them in a position quite close to extension. And this is a way we can try and bias the lateral hamstring. In essence, what we're trying to do is just get the remaining hamstrings functioning as best we can, just to limit any ongoing issues and dysfunction. but a lot of the time they will really struggle with top speed running. That last example I showed with the big defect in his posterior thigh, he was able to return to football and played several seasons, but unfortunately he had to adapt his role. He was known for being very explosive and quick outside winger, and he spent a lot more time in the midfield where he wasn't really kind of getting out of that third gear and hitting those top speeds like he used to.